As you know, Heather, you've been involved in reviewing very thoroughly our patient information booklets. So these patient information booklets are produced in collaboration with patients and carers for every single step of the bladder cancer journey. What are your thoughts, Heather, on these booklets?
I'm absolutely delighted that these have been produced, to be honest. I think it's been something that we've been needing for quite a long time. The information that's already out there is limited and is quite hefty in booklets that cover a lot of things at once. It's very difficult to know when in the patient's journey to give them a booklet. For example, if somebody's coming in with a suspected bladder cancer, you don't know what kind of bladder cancer it's going to be, so you don't know which booklet to give them. So you don't want to give them a booklet that's going to have loads of wrong information or inappropriate information. So often the patients don't get any book until they've actually been diagnosed, but actually, you know, they have those questions and those anxieties at the beginning. So with these booklets, the way they're broken down, there's a book for every stage. So at every point, the patient can go away with something in written format as well to look at, which I think is really important, although we always try and explain to the patients and describe what's going to happen and what the next plan is. It's very difficult for patients to take all that information in, I think.
For more information about Fight Bladder Cancer, you can visit this link, or you can scan this barcode with your smartphone camera.
So welcome to the session on the evolution of minimally invasive surgery in UK urology. I'm co-chairing this session with Professor John Kelly from University College Hospital, London, and my name is Nikhil. I'm a consultant urological surgeon at the Lister Hospital in Stevenage. In this session, we have three esteemed speakers. Mr. Adrian Joyce will be speaking on the in vivo years of national mentoring with the development of laparoscopic surgery in the UK. Professor Naeem Sumro will take us through the learning curve and how the robots have taken over. And Professor Prokar Dasgupta will then talk to us on the next steps taking place with urological surgery in the era of artificial intelligence and machine learning. So very exciting session awaits us all.
Hello, this is Adrian Joyce. I would certainly like to thank BAUS and the programme organisers for giving me, a silver fox, the opportunity to review the development of laparoscopy in UK urology, a technique which has certainly defined my career. Tribute has to go to these two men who in the late 1980s had the incredible foresight to see that laparoscopy was the way forward for urological surgery at a time when many had a very contrary review. John Wickham approached me when I was a senior registrar on lithotripsy duty at St Paul's with that immortal phrase, "What are you going to do with your career, my boy?" and suggested that I go to Germany and see Kurt Sem, a pioneering gynecologist who was undertaking laparoscopic surgery. The problem was when you went to see Kurt Sem, you didn't see very much because he would operate with his eye to the telescope, manipulating instruments through the ports, and then would stand up and say the operation was over. So I came away a little less than enthused that this really was the future direction. Malcolm was appointed consultant urologist to King's in 1989, and I was his first senior registrar. There's no doubt that he was a real pioneer, an early adopter of technology, and was not afraid to change the way forward. We'd already started doing simple laparoscopic procedures such as varicocelectomy and pelvic lymph node sampling. At the AUA in 1990, we were sitting together when Ralph Clayman presented his first 4 cases of laparoscopic nephrectomy. And Malcolm leant over and whispered, "We can do that." And true enough, in 1991, we undertook the first laparoscopic nephrectomy in Europe in conjunction with John Wickham. A few months later, we put on a one-day course, Laparoscopy and Urology at King's, with John Wickham. And you can see from the programme that this really was influenced by John's thinking at the time, that it wasn't whether you were a general surgeon or gynecologist or urologist that should do the procedure, it was whether you had the innate skills and competence. Certainly a view that was contrary at the time, but was shared by Kurt Sem, who was vilified by the German general surgeons when he suddenly announced that he'd undertaken a laparoscopic appendicectomy. The content of the course very much went into the format of our book Laparoscopy and Urology, which was published in 1994. Elspeth McDougall in 2003 had highlighted the specific issues relating to various minimally invasive therapy. In traditional open surgery, used to a 3D vision and tactile feedback sensation, whereas in laparoscopy, our vision is reduced to 2D and you certainly have reduced tactile feedback. The other difficulty is that dissection planes are generally vertical rather than horizontal as seen in open surgery. If one went back to those who attended that one-day course a year later and asked, were you practicing laparoscopy? You generally got three views. There were certainly practical concerns in relation to the level of instrumentation. There were many who found it technically demanding and had not pursued it. The others would like to, but felt that the frequency of the procedure meant that they weren't able to keep up their laparoscopic skills. When it came to the camera, we had no CCD technology. Chip on a stick was what you got in McDonald's rather than the operating theatre. We were limited to a small screen size. We had no high definition, and we had problems with loss of light if you encountered bleeding due to an inability to compensate. From the instrumentation, there was very much a one-size-fit-all, and many of it came from the gynecologists. We did have disposable and reusable ports, but the disposable instruments were generally limited to a grasper and a scissor. There was no formal right-angle grasper, and I treasured in 1995 when KeyMed lent me a 5mm right-angle grasper for being able to dissect around the renal hilum. Cautery was generally monopolar diathermy, and many, as did Ralph Clayman, used the diathermy hook when performing their laparoscopic nephrectomies. We had no hemolocks, but did have metal clipper pliers in the endo-GIA. There were needle holders, but very few of us had any laparoscopic suturing skills. And retrieval bags for solid organ removal was very much handmade out of usually parachute fabric. One had to be really assiduous in care of the reusable instruments. The problem was that the insulation would wear thin at certain points, and these would act as leak points when you used diathermy, causing a thermal injury outside the line of vision, which could lead to devastating problems post-operatively. Towards the middle of the 1990s, as laparoscopic surgery was becoming more prominent, also rose the fact that there were significant complications, and the press began to pick up on injuries relating to this new technology. Many surgeons were blaming the fact that they were still on their learning curve. Now, the learning curve is the point at which a new technique provides comparable outcomes to those which are usually achieved with traditional open surgery. And the factors that impact on that learning curve can vary from caseload to one's equipment levels, whether or not you've had prior experience or do have an innate capability, and what level, if any, of supervision you've been having. And the concern was, with the learning curve, was that if patients were countering problems, should they really be the ones to count the cost? If one went back to that group who went to that first laparoscopic in urology course, and we had over 150 delegates at the time, and delved really deeper into the questions and answers that they were giving, it was really a lack of training that was the problem. They were outside their comfort zone doing this technology and really wanted proper formal training to make them feel competent to do this procedure. We've already mentioned that laparoscopy poses quite significant psychomotor challenges for the novice due to that loss of 3D depth perception, the fact that you have reduced tactile feedback, and there is also a third compounding factor, which is the fulcrum effect of the body wall on instrument handling. And if your port is in the wrong place, it can certainly make difficulty doing the surgery. With the right program, you can generally get people to become competent in that field. Some may take different areas of time, but it is achievable. By 2000, there were definite drivers for change. Technology had come on remarkably, and we had better cameras and better instruments. There was a greater expectation of the patient for having their procedure done laparoscopically. So there was a pressure on us at BAUS and the section of endourology to come up with a program that would eliminate the morbidity associated with the learning phase of this new procedure. But this had to be done within a program that would counter the pressure on cost and theatre time, which is part of our everyday work program. So the challenge was to come up with an innovative technique within the limit of less hours. However, we had a problem. The UK at that time had few training centres. It certainly had a lack of trained consultant manpower. And the UK health system doesn't really reward a hospital performing new complex procedures because the tariff of the old open operation is usually overcome by the cost of the new disposables, forming a problem for healthcare managers. So for us as the section, we had to decide the way forward. The first choice was we had to decide our marker procedure. In general surgery, it was the laparoscopic cholecystectomy. But for us, it had to be the nephrectomy. And this was a surgical leap beyond a standard cholecystectomy, for which we had to retrain the novice. So we put together a formal mentoring program in order to upskill the consultants to improve our trained manpower. The first of all had to go on a dry and wet lab course. This would take them through the operative steps of the procedure, the potential difficulties associated with each step in a didactic session, and then improve their hand-eye coordination skills in dry and wet lab settings. If they wanted to proceed further, they should then identify a mentor. If I was the mentor, I would ask them to bring the team to watch 2 cases. What we were concerned about was if we trained a consultant and he went back to his theatre team who had not been involved, they would not understand what he was trying to ask for from equipment levels during the procedure. So it was important that they involved their theatre staff who was going to go with them down this journey. They would then come and see me to watch 2 cases with the individual as the cameraman and his theatre team scrubbed up with my theatre nurses. We would then identify 6 cases for the novice stroke trainee to perform. We'd do 2 with the aim of doing 2 per day. I would do the first one and then act as cameraman for the remaining cases until the individual felt competent to be able to go solo. The final thing that we introduced with this program was that they should complete an audit form to collate their progress, which would be submitted nationally. And if needs be, this could act as a trigger for further visits if concerns arose. I'm grateful to Frank Keeley on the behalf of us at the section who put these guidelines together with Chris Eden, David Tolley and myself, which was published in BAUS in the BJUI in 2007. It's interesting to see that when the colorectal surgeons introduced their LAPCO program, they mirrored their program very much on what we had undertaken for laparoscopic nephrectomy. And it was interesting to see that they published that this program could show evidence of improved outcomes and reduced errors. The US had taken a slightly different approach using a 5-day mini fellowship. There was a high teacher to delegate ratio, which I think was the bonus, and it was 5 days of didactic tutorials, hands-on skills in both an animate and inanimate session, and lots of discussion over clinical case scenarios with video. And it was interesting to see that after 3 years, still over 70% had maintained their desire and operative skills in undertaking laparoscopic surgery. This was the pro forma for audit completion. Although a cumbersome process, at the time it was a national first and did have a reasonable return rate. The main criticism we had was that it had not included any risk factor stratification process, such as an ASA score or a Charlson comorbidity index, which we rated corrected in the national outcomes process. When it comes to auditing of data from new technology, if I had my time again, would I change matters? I think it is certainly important to separate the surgeon from the data collection. They're busy enough. And one could use the data collection using hospital coding systems to provide you with the operative procedure. All the surgeon has to do is check the risk stratification with relation to ASA and the Charlson comorbidity index. One could then use outsourced patient-reported outcomes delivered by a third party to achieve your follow-up data. And all the society, section or association has to be involved with is the standard setting, the data analysis, and whether any quality improvement changes need to be addressed. I think the introduction of laparoscopy has certainly taught us that no longer can we rely on the see one, do one, teach one school of surgery or the apprenticeship system. I'm proud that the section has shown that laparoscopy has set the standards for the introduction of any new technology and that this should be based around a structured training program with a national audit of results. 100 years ago, Lord Moynihan came up with these words in relation to surgery, and I think they're very apt in today's modern, minimally invasive, laparoscopic and robotic era. Many have asked me whether now that we're into the robotic era, what is the role of laparoscopy? I certainly think it does have a major role still in upper tract surgery. And there is a definite role in financially challenged healthcare systems who struggle to afford the robot until these costs are reduced, for them to perform minimally invasive surgery through the laparoscopic alternative. I'd like to thank you for giving me the opportunity to review the development of laparoscopy in UK urology. It has been an honour. Thanks.
It was exactly 20 years ago in Birmingham again, when Nikhil presented his series of 360 cases, which were done laparoscopically. That was a time which gave a jump start to laparoscopy in urology. I was actually among the first urologists who went to see his work in Cleveland Clinic in 2001. Then I went on to stay for 2 weeks in Johns Hopkins as I was interested in lap donor nephrectomy as well as lap renal surgery. And I'm very conscious of the fact that laparoscopy or conventional laparoscopy has really taken roots in urology, and we are, because of the decisions taken by our leaders 20 years ago within BAUS, and I would also say support of the Urology Foundation, which has taken to a place where we can really be very proud of our laparoscopic skills among trainees and surgeons. However, today I'll make a case there's time for us to move on. Now, in my position as Director of Robotic and Digital Surgery for Royal College of Surgeons, I had the opportunity to look across all surgical specialties, and I'm going to give this talk with that background in my mind. In the last 2 years, the Royal College of Surgeons have taken over the initiative of developing and delivering an ecosystem which allows robotic surgery to be encouraged across all surgical specialties. And we have been working on 4 themes. One theme is looking at clinical research, to undertake research in pure robotics, in data science, in system analysis, which will allow and facilitate robotic surgery across all surgical specialties. We are also working with Health Education England to ensure that we develop workforce or future surgical workforce which is conversant with robotics, data science, and AI. We are engaged with industry partners. They are robotic companies, surgical platforms, mixed and augmented reality companies, and also data companies to make sure they come and invest in UK and also work with us to facilitate and develop that ecosystem. And most importantly, we have been working with NHS England and Department of Health to inform, advise, and influence so that the policies and the regulatory structures are aligned, which facilitate development of robotic surgery. Now, what's the challenge that we have that we need to impress upon the policy holders? If you look at the left side of my slide, although it is not commonly known, but when you talk about cancer surgery, normally the impression comes in a patient with a drip or patient sitting in a cyclotron to having radiotherapy. But almost half of the patients who got cancer in UK, their treatment is surgery, not chemotherapy, not radiotherapy. But when you look at government policy document, 10-year forward view, although there is funding for different cancer treatments, say 400 million pounds each year for cancer drug funds, for drugs which have still no evidence of their efficacy, and in best case scenario would increase life expectancy by 3.4 months. And there was funding for new cyclotrons and also proton beam accelerators as well. But in that chapter, which focused on cancer surgery, there was no mention, on cancer treatments, no mention was made of cancer or surgery as a treatment for cancer. So there is a lack of understanding at national policy level about importance of surgery in cancer. The second aspect is that 1/3 of all hospital admissions in hospitals are for a surgical procedure, that between 7 to 10 million admissions each year. And the third sad fact is that 1/3 of all patients which die in UK die within 90 days after a surgical procedure. So our ultimate aim should be that we want to decrease harm, and we also want to decrease that 90 days mortality after surgery. So this is our challenge. So have there been any implications of lack of investment in surgery, whether it is in research, whether it is in policy decision making? We have known for the last 30 years that for lung cancer, for rectal cancer, for colon cancer, and also for uterine cancer. If minimally invasive surgery was done, it was better for the patient, and oncologically, it was as good as open surgery. And we have been trying to train surgeons in those areas. But if you look at these low part of these slides, around 45 to 60% of the patients have minimally invasive surgery. Still, half of the patient in these cancer groups have open operations in UK. So we have failed to offer equitable cancer service to these patients. But when you look at the top slide, which is very encouraging, when you look at urology, last year, 98% of all patients who had prostate cancer, they had their operation by MIS route, and 92% of those was because it was done robotically. The same applies to partial nephrectomy. 88% of the patients who had small kidney tumors had minimally invasive surgery, and 82% of those was because of robotic surgery. Similar applies to radical cystectomy. 55% of patients had minimally invasive surgery, and 52% of those were because of robotic surgery. So I think we are years ahead and miles ahead of other surgical specialties. We started late, but in robotic adoption, we are the one everybody talks about. That how have we done that, and how we can follow urology. But the last thing that we look at is about nephrectomy. So what is happening with nephrectomy? Yes, we are doing good. About 77% of the patient have minimally invasive surgery, of which 73% have it laparoscopically. Now, overall, we have a very good adoption of MIS. But when you look at underneath, you see about 20% of these patients who had laparoscopic nephrectomy were T1A tumors. So we are doing unnecessarily too much radical nephrectomies for small kidney tumors. And I'm quite confident that if you move all of these patients towards robotic nephrectomies rather than laparoscopic nephrectomies, about 20% of those would go on to have partial nephrectomies rather than radical nephrectomies. So I think the case that I'm going to make today is that we have to move from current third industrial revolution to fourth industrial revolution, which is based on robotics and data. And we should train all of our trainees in robotic surgery and part our company, sadly, with laparoscopy altogether. So that's the case I'm going to make. So whenever you talk about system change, and that is very relevant, the questions are asked, so what evidence do you have of what you're talking about? Can we afford it? And do we have the capacity to deliver what you're asking? And I'll say yes on all of those. Let's talk about evidence. I think we have had 20 years of genetic evidence whether robotics is as good as laparoscopic or open, but I'm not sure that we have been asking the right question. And I'll say why. Because first of all, you look at methodology. The question is, are we using the right methodology to ask complex technological questions? Because in all of these randomized trials, I think there are significant qualitative methodological concerns that many people, including myself, have. Because in these studies, the surgical quality assurance frameworks have not been applied, the primary outcome measures have not been looked at, and we have looked at very simplistic RCTs rather than look at much more complex adaptive designs like MAMS, clusters, stepwise designs, for example. In terms of undertaking trials in technology, it is not simply sufficient to say one technology is better than the other. We have to look at, in much more wider sense, on complex interventions. We have to look at which one is better adoptable. Laparoscopy may be as good, if we, for a moment, take that argument, as robotics. But as I've mentioned, it is not adaptable widely. It will leave huge population without any access to minimally invasive surgery. So we look at adoption, and the example I'll give would be VHS versus Betamax. Now, it is said that Betamax was better than VHS, but it was VHS which became much commonly used. So I think we have to look at how technology adoption is done rather than simplistic answers of effectiveness that is very good for drug trials, but not necessarily technology trial. The other thing is the scope. I think our scope has been very narrow. We have been looking at hospital episodes, and in terms of complication and cost effectiveness, looking at 30 days cost effectiveness. We haven't looked at system-wide evaluation, that if it was applied across a region, what will happen. And our cost factor analysis not had been wide enough over 1 year to look at total cost of treatment. And we also not looked at utility, scalability, and acuity of access. And these are my point, that although we have evidence, I think we haven't got the right kind of evidence. And that's why we haven't made a good case. And when you look at some analysis has been done, and this is about partial nephrectomy, looking at 5 parameters of length of stay, transfusions, complications, conversions, and readmissions. And this is based on HES data 2018, 2019. When you look at these and compare open versus laparoscopic versus robotic, and you look at the lower part of the right slide, every time an open partial nephrectomy is converted to robotic, there's a saving of 2,400 pounds. And when the lap nephrectomy is converted to robotic, there's over 500 pounds saving. And that is based on these price metrics, which are NHS own price metrics. Same thing can be applied to radical prostatectomy. So every time when we move from open to robotic prostatectomy, there's a saving of 1,000 pounds, and lap to robotic, there's a saving of about 500 pounds. And an economic analysis has been done that of all the other 4 major cancers in which current adoption of MIS is 50%, if you move them to 95% or 98%, the way we have done with prostate cancer, there'll be a total saving to the health economy of about to the tune of 50 million pounds each year. So that is how you have to look at system-wide change rather than looking at procedure versus a procedure, which I think is a very narrow way of looking at evidence. So the next question is, do we have the capacity and can we afford it? And my answer is yes, we have the capacity and we can definitely afford it. And I'll give you my argument for that. Just take, we have got, as I know, about 100 robotic systems in the UK working. Last year, there were 20,000 operations done using a robot, 12,000 of which were actually urologic cases. When you look at the productivity per system, it is about 200 cases per system, which actually accounts to only 40% utilization of these systems. So more than half of the time, these systems remain either underutilized or non-utilized. So there's a lot of capacity available, which we are not using. If we go up to 45%, which is an accepted capacity of a normal theater, we can add on an additional 20,000 robotic procedures without any capital investment in the UK. So there is inherent capacity available, which can be used by change in regulation, change in commissioning tariffs, and also by job planning and all the other things which we can use. So what about lap nephrectomy? Last year, 2,500 lap nephrectomies were done. And I think if we take it upon ourselves as BAUS, as urologists, there is no reason that of the 20,000 potential cases which can be done robotically, that we can't consume 2,500 cases for lap nephrectomy and start doing all of them robotically and train our trainees to do that accordingly as well. And the other thing is it cost effective? The answer is yes. When I look at the disposable cost of lap nephrectomy in our hospital, which is close to 1,500 pounds. When I do robotic nephrectomy, the cost is only 600 pounds. So robotic nephrectomy, once you have a system which is remained underutilized, robotic nephrectomy disposable are cheaper than lap nephrectomy. For all of those reasons, I will say, yes, we have definite capacity and we can definitely afford it. So I'm very convinced that we move in that direction. But my argument is much more wider. Robot not only allow us to perform operations better, and it's good for the patient as well. If you look forward, they also generate data. So every time a surgeon moves his or her hand, a data is generated, which is called, and which can be captured, which is called automated performance matrix. And this data can be used for an actionable, it can be actioned upon. And you can actually look at data coming from a competent surgeon over here between a novice surgeon. There's also data to suggest you can actually predict outcomes from USC, whether the patient will go home after 1 day or after 2 days, for example. We are currently undertaking a major trial in UK across 12 institutions in 6 surgical specialties, which will look at these APMs across 6 cancers and see whether we can see commonalities. So I think for the first time, we are able to capture the data signature of a surgical procedure. We still have to do more research in that, but I think that's one of the most exciting things which is going to come and in front of us in future. The second reason I say we should move towards robotics is that now we can use HoloLens or other similar hardware and software to train medical students. These slides are from Case Western, and they are being used to use medical students. And I'm sure many institutions in UK are also using HoloLens for the training purposes. But we can use HoloLens even much more widely in theater environment. We are working with Proximie, Touch Surgery, and other companies, Curricula, Microsoft, in which we can do 3D structures of the procedure that we are doing in theater environment. And within COVID-19 situation currently, we can use HoloLens so everybody doesn't have to go to ITU or to see a patient. People can stay back. So in that way, we can use immersive training, virtual reality to train. And during that, we can capture data as well. And that's a thing I think we have to do, that we can start from autonomous training to modular training to structured training. And that's how paradigm should be. So that's a second reason I think we should move towards using more robotics and virtual reality in our training. And what are the reasons? Currently, our CCT award is based on competencies, which is a standard set by JCST. But when you look at variation between the logbook cases and indicative operation between the surgical specialties, there's as much as 35-fold difference between the competencies that are required to become a competent. When you look at urology, a urologist needs to have 915 cases on the logbook and 18 indicative operations. But when you look at, for example, neurosurgery, a trainee needs to have 1,200 operations and ENT 2,000 operations. Now, there is no reason why there is so much variation. So this is a very subjective measure currently that we use to a certain competence. And I think in future, we have to use data to see whether somebody has become competent. And that is why I think we need robotics, because that generates data and virtual reality generates data as well. So how should the future look like? I think, first of all, we need to work at developing a robotic surgical curriculum. I know that BAUS and urologists have been at the forefront, and we have already developed a robotic surgical curriculum, which other surgical specialties actually are adopting. And I think that it should have 4 components to it. First of all is autonomous training, which trainees can use online modules and to go through a program called robotic literacy, so they know how to set up a robot, safety of a robot, and all of those things. And it should be part of CCT training. The second component, I think, should be modular training to learn basic skills using augmented or virtual reality and simulation. The third component should be surgical skill hubs. That is procedure specific. You may go through dry or cadaver lab. And I think in future, we probably start using more 3D printed parts and also distant mentoring as well. And in terms of assessment, I think there should be structured. Currently, we look at gears and nodes as an assessment of training. I think we need to look at technical skills and also team building skills as well, additional technical skills. But in my opinion, in future, all of these would be underpinned by automated performance metric data that you'd be able to tell that person is going through a training or have become competent in certain specific areas. So I think that is how we need to reform or transform surgical curriculum. So where this surgical training should undertake, my view is that we need to have regional digital skills hub in which we train surgical workforce. But these are physical spaces and also virtual spaces as well. So I think we can have virtual courses in addition to physical space to come in. And again, they should be based on 4 areas. Augmented reality, that's one pillar, which I mentioned before. Simulation is a second pillar. Robotics which this trainee will be trained on. But most importantly, I think we need to have surgical trainees focusing on machine learning. And I'm sure Prakash will talk more about that. But I think that should be the 4 components of training future surgeons, urologists, and those facilities should focus in these 4 areas. So how do we develop surgical workforce of the future? I think that is, first of all, developed by developing robotic and digital literacy. That means that our trainees should do MRes, MD, PhD programs in data science, in addition to molecular biology. I think the Royal College of Surgeons and GMC develop training and assessment standards. Now JCST, SSCs, and Surgical Specialty Association should develop surgical curricula, which urology is quite ahead of. At the end, I would say that Health Education England and robotic and digital companies should develop content, facilities, and deliver training. I think urology practice has moved away from manual surgery to industrial surgery, which is laparoscopy. And I think we move on to now a digital phase, which is based on data and data science. And what I would suggest is that BAUS should look forward and be bold and should make sure that we become lab neutral by 2025. And I should think that this picture should be part of our historical exhibit and not the future. Thank you very much.
Hello, everyone. We are living in very exciting times, the era of AI and machine learning. The question is, what does this mean for urologists? Most of you will not be familiar with the concept of AI, so let me make it very simple to you. Imagine you are roaming through a country whereby you do not know the language, and there's a sign suddenly which comes up. You take your mobile phone, put it up to the sign, and it tells you, beware, cliff ahead. AI just saved your life. But even more, lady in Somaliland, she has put up her phone in front of her crops to see if there is any disease affecting these crops. So what we're trying to say is AI is going to change the future only if it is AI for everyone. That, of course, includes us as urologists. You will come across a number of these terms: artificial intelligence, machine learning, deep learning. Each has a slightly subtle difference, and I will go through those that apply to you. Mainly the concept of machine learning and what does deep learning really mean. So look upon this very simply. Machine learning is 2 things: using data to answer questions. That's all it is, using data to answer questions. There are 7 steps to machine learning that you need to understand. If you're going to use data to answer questions, then you first have to gather data. Gathering data alone is not enough. You then have to prepare that data, because unless you clean it, it is just garbage in, garbage out. So you gather it. The second step is you prepare it, and then you choose a model for that data. Let me give you an example of such a model. Say you have got a crate full of beer and a crate full of wine, but they're all mixed up together, and you somehow need an algorithm to tell you the difference between beer and wine based on the color of beer and wine. So you need to then design a model that can tell the difference between the 2 colors. Once you've done that, you go to step 4, which is training that model, and step 5, which is evaluating that model. This means that, say you have 500 patients, a data set from which you want to answer some important questions. I would use 400 of those data sets first, which is 80%, to train that model, and then evaluate it using the other 100, which is the 20% of the data set, to evaluate the model. Now, the model is not going to get everything right first time. This is just like training to become a surgeon. You train, and you train again. So you then do what is called parameter tuning. So you refine the model, and ultimately you get the correct prediction of the output. So these are the 7 simple steps of machine learning. So why do you need a model? Look, this morning, we all received 200 emails in our inboxes, and some of them are spam, as in red, and the others are the real emails that we want to read, which is not spam. And if life was straightforward and simple, the spam and the non-spam would be in clear demarcated areas. So the model would just be a crisscross across, separating the red from the blue. But life is not like that. The problem we have is spam is mixed amongst the non-spam, and therefore you have to design a model which is almost circuitous to take away the red from the blues. So this is not an easy task, and this is where you need someone, an expert in computer science, an expert in AI, to design the correct model for you. So let us talk a bit about convoluted neural networks and deep learning. So all of us have a brain which literally controls everything that we do, and the brain has these little synapses which take a signal from one point to the other. So if you look at this, so left hand, and on your screen you will see these also look like synapses, so they are what we call a neural net. And because it is designed like this, it's called a convoluted neural net. So just imagine this neural net trying to read the number 9 and recognize it. Number 9, what you do into 784 pixels like here, and that is the input layer. And then at the end, you want the output layer to recognize this 9. You put it through a number of hidden layers which are not visible. And if you have more than one hidden layer, that is simply what we call deep learning. So the network then passes these signals through the hidden layer. Initially, it will not get it right. 9 may be recognized as 3, but then it will backward propagate these signals. And here is the difference between a neural net and the human brain, because the human brain has synapses and nerves which will transmit signal in a particular direction and not in the opposite direction. So the back propagation is what makes it different, and the back propagation happens till it is recognized as the number 9 in the input and the output layer. So I hope that is very clear and simple. And to make it even simpler, I will show you a short video from my favorite journal, Science Magazine, which will absolutely clarify things to you. Take a look at this.
Say anytime you're talking to your phone, that's pretty much a neural net doing that. It does really well on image recognition. Autonomous cars coming soon. The top flight method for genetic sequencing is a neural network. You can say they're loosely inspired by the brain. It is a network of neurons. People call it neurons. They're all connected to each other, going down through the layers. In a way, they mimic neurons in that they're little triggers. Each neuron has kind of a threshold called a weight where it makes a decision. So it takes in data, could be a huge amount of images. And then once the network is trained, you can put one image in at the front. They fire when they see the thing they want to see. So you get this kind of cascade moving through the neural network. And that does really poorly. It just does horribly. But there's this little magic trick called backpropagation. And this is very unbiological. Your neurons don't do this at all. But at the end, you're like, okay, well, you were wrong, but here's a proper picture of a dog. And now you send all that information back through the network again. And the network learns just a little bit better how to say, oh, this is a dog. It's elegant math, and really the breakthroughs in the field were when they stopped trying to be so biological in the 1980s. At the time, they didn't work that great, but turned out all they needed was a huge amount of processing power and a huge amount of examples, and they would really sing. So in many of these cases, accuracy is enough. But when you're talking really life and death decisions, driving an autonomous car, making medical diagnoses, or pushing the frontiers of science to understand why a discovery it was made. You really need to know what the AI is thinking, not just what its results are. Since you have all these layers, it just engages in such complex decision making that it just is essentially a black box. We don't really understand how they think. All is not lost for this.
So, very, very exciting technology, but what are the clinical use cases? This is one of the first. This was from the Moorfields Eye Hospital, and this was a collaboration with Google. This is diabetic retinopathy, and this was trialed in a number of countries, including India. And guess what? Not only could it predict diabetic retinopathy better than an eye doctor, but it could in addition predict that you may have a cardiovascular event as a result of your diabetes 2 days before it was actually due to happen. An amazing, amazing path to discovery and translation into human benefit. But here is another example. This is an example where AI has not been that successful. You would say, well, this is a prostate cancer. Why actually have arguments about whether this is a Gleason 4+4 or 4+3 or 3+4? Why don't we use an algorithm to do precisely this? The problem is this is one of the failures of such an algorithm. So data was taken from a number of hospitals. The algorithm created, it was fed with that data, trained and tested, and then they found a human being. Why? The problem was something called label leakage, which is a kind of cheating. What happened is the algorithm thought that the data which came from a particular hospital, which was called the Kaiser Permanente Cancer Hospital, for example, were all cancers. So everything that came from that name meant that everything was a cancer, which clearly was not the case. So the algorithm got confused and label leakage happened. So it's always that you will gain success in machine learning algorithm. The person who has really led its transformation into urology is my friend Andrew Hung, who used to be consulting editor for AI when I was the editor-in-chief of the British Journal of Urology International. And this is one of Andrew's papers in JAMA Surgery. I want you to focus on what he has done, which is APM, so automated performance metrics using machine learning. What does this mean? So here is of a robotic assisted radical prostatectomy. As you know, now 90% of all radical prostatectomies in the United Kingdom are now performed robotically. Would you believe it? 17 years ago, it was just 1% when I started. And now 9 in 10 are done like this. But can we then take this video and improve or judge performance? The answer is yes, we can. You can feed this information into black box, the black box which was described in that science video, and that will look at systems data, which is the movement of instruments. Kinematic means movements, and then the events that happen as a result of those movements. And we are actually embarking on a very exciting study, not just in urology, but across surgical specialties using precisely this black box technology, and it's called the RCS Mastery Study. So watch this space. And then you get what Andrew describes as automated performance metrics. So for example, here are 8 surgeons in Andrew's own department. The best surgeons, or the most experienced, are in blue, and the lesser experienced surgeons are in orange. And you would think, based on what we know, that the more experienced the surgeon, the better the outcomes. The machine sees it differently. This is paradoxical. Look, top 5 features based on APMs or performance metrics is different. Surgeon 1 ranks there. 2 is perhaps not as good as surgeon 3, despite being high volume, is there. Surgeon 4 somewhere in between. And here are some other talented surgeons who have less experience, but get as good or better outcomes such as continence and erection. So a machine can see surgical performance very differently. And I think there's a lot to be said about how this can influence the future of surgical practice. What about other things? What about these wonderful MRI scans that we take? This is the MRI of a prostate gland, now standard of care before we take a biopsy in a patient for a raised PSA. And this is called the ArtMap project. The machine learning company is Jiva AI. This is one of the companies that I mentor from the National Clinical Entrepreneurship Program led by Tony Young, my dear friend. And this can now predict a cancer versus no cancer in nearly 90% of MRIs, thus giving an additional value to a radiologist's report. Radiologists often cannot decide whether something is a PIRADS 3, 4, or 5, and there is concern within the UK and internationally about the wide variations in reporting. Here is a tool which could potentially reduce that variation because the machine thinks very differently from a human being. What do we do then with those static images? Here is such a static image. We can use an AI algorithm to actually automatically volumize the image. You can see this being volumized in an automatic fashion. And once it has been volumized, you get a 3D image like that. This is a complex structure, which is the heart. You press a button, and overnight, it gives you a 3D printed model. This can actually help with surgical management. So here we are. This is the 3D printed model of a prostate in a patient with T3 cancer. This is the sphincter here, and this is the actual prostate that has been removed. You can see it is literally a millimeter from the sphincter, but far away from the nerves. In these T3 type of cancers, consistently the problem is that we have 35% positive margins even in the best hands. And here is an ideal phase 2A study showing that using 3D printing, you can reduce the margins to 10%. So this has, again, considerable translational value to patients. What about AI and machine learning to predict the recurrence of prostate cancer after a robotic-assisted radical prostatectomy? We would do this with traditional statistics. Here are 3 machine learning algorithms, all performing better than traditional ways of return of prostate cancer and its subsequent treatment. This actually won the Global Prize last year and was published in the BJUI. If you want to perhaps spend a little more time learning about the application of artificial intelligence, I would recommend you this paper, which Andrew, his team, and I collaborated on. And it gives you the state of the art, over 110 articles here, into 4 classifications: diagnosis, outcome prediction, treatment plans, and surgical skills evaluation, such as here bladder cancer biomarkers, PCNL outcomes, drugs for castrate-resistant cancer, and laparoscopic skills evaluation. So already we have a significant volume of literature, and we will be adding to these as the next 5 or 10 years. In the Platinum Journal, Nikhil Vasudev, who is co-chairing this session, is an author with me on this. And this is the role of AI in our fight against COVID-19. Why should this be of any interest to you as urologists? The reason is this. If you use a paper from Jack Shalkin, a famous scientist in the prostate cancer field in Nijmegen, you'd look at this and say, I really, as a urologist, would not be bothered to read this. But this deals with a kind of gene fusion, which is called ERG and TMPRSS2. So I got David Bostwick, a famous pathologist, to explain this to a child in very simple terms, because this is, to me, very exciting, and we need to understand this. So look at this simple diagram. This is the short arm of chromosome 21. This is the long arm. On it, you have ERG here. You have TMPRSS2 there. And the reason this fusion happens in 75% of prostate cancers is because either TMPRSS2 translocates or the genes in between get deleted. Even a kid can understand that. And this is why AI is going to become of interest to urologists in the COVID era. Remember TMPRSS2. So this is even more interesting. You will remember from your school days that all our cells have a membrane. Imagine this is the cell membrane of nose is where the virus attacks you. The virus has these little spike proteins in it, and it attaches, guess what, to the ACE2 receptor. ACE2 comes from renin-angiotensin axis, and underneath ACE2, what is called the endodomain, here is TMPRSS2, which we have already detected to be of interest to. So we are currently at ways of blocking TMPRSS2 with dutasteride or anti-androgen therapy in response to the COVID pandemic. The way we are trying to do this is use already existing apps. This is the Zoe app from King's College London, published in Science and Nature Medicine, whereby we can interrogate the app, which has already got data on millions of patients, to see if those on TMPRSS2 blockers had lesser chance or lesser ferocity of COVID. So this is of absolute interest to urologists. The other thing that happened as a good news during the pandemic was we got 11.7 million from the EPSRC, or the Engineering and Physical Research Council, something called Trustworthy. Press got hold of it and they interviewed me. They said, look, 28.4 million operations will be canceled. Can a robot really help you in theaters, improve capacity? And I said, look, this is science fiction. Yes, a robot can automatically do certain things better than a human being, such as putting sutures, but we still need human intervention to make sure that an operation goes well. So this is far-flung, and we are nowhere near achieving this. This is in the future. We can't really be sitting there as surgeons having coffee and our patients think that a robot is operating on them. Most of them would not accept such a situation. But what patients would accept is transporting an expert surgeon wherever they might be to another part of the earth. And this is an augmented reality platform to which I'm the chief scientific officer, called Proxime. Again, comes from the National Clinical Entrepreneurship Program. You can download it onto your laptop or tablet, and you can guide a patient from anywhere. For example, during COVID, my colleague Archana Fernando was helped by a senior colleague all the way from Seattle, 5,000 miles away. This made headline news in the Sunday Times and Sky News, to do a retroperitoneal operation and actually do that robotically without the expert being in the room. So this is one such operation that we did nearly 3 years ago, where here is my my fellow in the operating room. That is my hand. This image is transmitted by Proxime into the robotic console. He can hear me, I can guide him. I am nowhere to be seen. But you can see the benefit of this in democratizing surgery as a proof of principle. So again, this is undergoing trials right now. This guy who was the patient in this case was actually a BT engineer, so he loved this because this was right down his street. We have taken this concept to describe something called Internet of Skills, and Misha Dola, my colleague, who is the head of telecoms, coined this terminology for the first time in King's College London, along with Ericsson, who, as you know, are a famous telecom company. Hongbing Liu is my senior lecturer and an expert in haptics. And so let me describe this to you. There are 3 challenges we have in order to transport surgical skill anywhere on earth. The first is the delay, which is called the time delay. The human brain can deal with 10 milliseconds, but if you then go from London to Los Angeles, in this case, it was London to Seattle, you need to reduce this time delay. Otherwise, your movements will not match those of the surgical instruments. The way we do that is use 5G networks and then some artificial intelligence. The second challenge we have is the artificial intelligence itself. We call this the paperclip conundrum. What does that mean? If you get an artificially intelligent algorithm to distribute paper clips on Earth, and say it gets to 3 billion people and then realizes it has run out of paper clips, it will just kill the rest of the world's population. That is not acceptable. So we have to create AI that is explainable and responsible. And the third challenge we have is soft robotics. Today's robots are little pulleys and wire system. They are not very good for transmitting the sense of touch, because that's what we are trying to do along with reducing delays. So we use what we call haptic codecs, and we have been busily designing these soft robots, octopus and to deal with this third challenge. And what we have done is we have used a glove, which is called the neurodigital glove, which can feel inside a patient without making an incision. We have used HoloLens as the visual aid. We have now a patent on this. This is a 3D printed gripper. And in between, we have used real-time slicing by 5G. The first description of this, a pioneering project, was 2 years ago on Facebook Live. And guess what? Very soon, it is followed by 5G remote surgery by our Chinese colleagues. I just wanted to finish by not just talking about AI and machine learning and what it might do to urology, but what is the future for surgical science in general. So this is from the Topol review, which was commissioned by the British government. And you will see there are 10 things here: telemedicine, smartphone apps, and others are already here. Virtual and augmented reality, I have shown you. Automatic image interpretation, particularly for breast cancer and prostate cancer using AI, I have shown you. And predictive analytics with AI, for example, early warning signs like I showed you during COVID. These things are already here. What is most challenging is writing the genome, which is called genome editing. And I have some very exciting news for you on this. Some of you will know just last month that Doudna and Charpentier won the Nobel Prize for this technology. If I was a young researcher today, this is what I would spend a lot of time on. In fact, we have brought in a senior lecturer into our labs from the Sanger Institute in Cambridge to do precisely this. This is called CRISPR-Cas9. Let me describe this to you. Say you have a single prostate cancer cell. These are the strands of DNA, and you have located a problem here whereby you need to get rid of this segment in order to change or edit the signal within the cell. So what you then do is you introduce RNA, and then you introduce an enzyme called Cas9 to actually cut away the disease segments and insert the correct segment from this guide RNA into the DNA. This is very, very exciting, has been very controversial in fertility management, but also during COVID has made a lot of noise, and as I said, won the Nobel Prize in 2020. So watch this space. If I was a researcher, young researcher, I would certainly study CRISPR-Cas9 more in detail, and particularly its relevance to cancers. Finally, how does anyone learn about all this? We are clinical urologists. How did I learn about all this? Of course, I went to Google AI and did their course. I went to the Oxford AI course and did a diploma. But I also read this book, which is by one of the head of school in Northeastern, called who's a friend of mine. And he describes a specialty called humanics, whereby you have to learn 3 things. The first is tech literacy, whereby you can go to coding camps. The second is data literacy, whereby you learn about data science. These are all available online, so you don't have to actually travel to learn this. But the final thing, which is the most important, is human literacy. What is it that machines can today do better than us? But more importantly, there are many things that we can do better than machines. So I don't think AI or machine learning is going to make us obsolete as urologists or surgeons. It is going to help us understand the ecosystem better and will work with us, because you still need human judgment, your judgment, to perform an accurate operation for your patients. So thank you very much for having me. It's a real pleasure to speak to you about the future for robotics with AI and machine learning. Thank you so much.